Hey Jessica, hey Luz. Can you all hear me? Good. Okay, that's fine, Luz. Luz, Hector never sent us a bio, right? I asked him again, but I didn't receive any, so I don't know what to say about him. I may ask him to say something about himself. Yeah, I found the picture, the photo, but not the bio, so. Hello, Hector. Hey, Jessica, do you know why you can't speak or share your video? No, we cannot hear you. Anyone else can speak? It seems like it's just me. Okay, Hector, can you call me? I have given you my cell phone number in the email, so I can guide you how to connect as a speaker so that we can all hear you instead of me being the speaker here.
Unmuted.
Hey, Hector, I send you an email. Just please log in by that email. I'm going to log out, and then you log in with the information that I have sent you through the email. Can you hear me? Thank you. Like this. So I send you an email. That's our this is the login and PIN information, password information. If you would go with that. Hey everyone, I'm so sorry for the problem that we have. Just bear with us. We will fix it. Thank you.
Okay, can everybody hear me? Well, now I cannot hear you. Let me see what's going on. Can somebody talk? Because I don't know if you're hearing me. Okay. So I'm assuming, but everybody's, are you seeing the slides? Okay. Just let me figure out how to share those slides with you. Well, I might be able to share my screen. Oh no, I can't. Here it is. Okay. I'm assuming everybody can see the slides now? Perfect. Okay. Okay, so let me introduce myself really quick because Asita won't be able to do it. I'm an associate professor at the School of Nursing at the University of Texas at El Paso. I'm also the director of research and the co-director for our interdisciplinary health sciences PhD program. I'm not a nurse, although I'm surrounded by them both at home and here at school. And I'm primarily interested in health disparities. And I got here from an exposure science perspective. And for the last 10 years or so, I've been transitioning into social epidemiology. And I'm going to talk today to you about one conceptual framework that came from a fellowship program that I'm a part of. This is a fellowship program funded by the JPB Foundation, and two of their programmatic interests are poverty and the environment. And this fellowship program, which is housed at the School of Public Health at Harvard, it's interested in the intersection of those two areas of interest. So in broader terms, it's interested in environmental health disparities. As we met for 4 years from 2014 to earlier this year, it became obvious to us that there was a need for a conceptual framework that allowed us to systematically tackle the questions that we were interested in. So the fellows, we decided to work on developing this model. Today, I'm going to tell you a little bit about how the model came about, its key components. I want to give you an example, an applied example of how the model could be used to develop more detailed conceptual frameworks that could actually guide research. Because this model is a little broad, but it was necessary that way. And I think one of the objectives for me today is to sort of prove that concept and how it can actually be applied, because I don't think that's obvious from the manuscript, and how we think it could be actually very useful in guiding research in this new field forward. And then I'm going to provide as a summary work that we think that needs to be done, and I'll share a little of what I'm doing here that fits into the model. So I'll go. I know we're already behind schedule, so I'll try to hurry up at the beginning because I think the coolest part of the presentation it's towards the end. So again, I already mentioned that the model came from the fellowship. Ultimately, 5 of us ended up working more consistently in it, and these are my co-authors. Allison is my co-leading author. We drafted most of the manuscript together, but everybody here worked really hard for more than a year, putting all of the ideas together. And the rest of the fellows, there's 12 of us. Well, there's new ones, but they didn't work on this. But the first cohort of the fellowship, there's 12 of us, and everybody contributes somehow to it. So I do want to acknowledge that this came from the fellowship, and all fellows had a lot to do with how the model came about. We were motivated by a couple of things. As all of you, I'm pretty sure, know, this is obvious. Research happens in silos. And as much as it has become interdisciplinary in the last couple of decades, we're still far from it being real mainstream. And in terms of health disparities, which is a perfect example of where interdisciplinary research is necessary and it should be the norm. Here's where siloed research has its biggest impact or the biggest shortcoming. So let me provide a couple of examples. So for instance, in the case of stress, it's clear that it's associated with health. There's an enormous body of literature that shows that. Here as an example, stressful life events and metabolic syndrome. There's research on this. It's fairly new, but again, it happens in a silo, stress and metabolic syndrome. Air pollution as an environmental pollutant, also it's associated with metabolic syndrome. And these are fairly new articles. So this is something that it's barely coming about. The metabolic syndrome stress, metabolic syndrome, and air pollution. These two exposure factors, they're associated with socioeconomic position. So stress, it's patterned by socioeconomic position, and air pollution exposure is patterned by socioeconomic position as well. What does that mean? The obvious, that socially disadvantaged individuals and communities are usually exposed to both, to greater levels of psychosocial stress and greater levels of air pollution in this case. But that idea can be expanded to a wide range of social stressors or social factors and a wide range of environmental factors as well. Access to green space, water pollution, soil pollution, noise, and from the social perspective, crime, access to food, to healthy food, so on and so forth. So it's obvious that socially disadvantaged individuals and communities have this sort of double jeopardy problem that they have to deal with. However, in the public health literature, these have not, in a mainstream form, been addressed together. And we think that by not addressing these two set of factors together from the perspective of health disparities, we are assuming the risk of considerably underestimating the effect of social disadvantage on health. We're not classifying properly, we're not identifying magnitudes of effects properly, we're missing important pathways connecting exposures with outcomes. And the reason that an accurate assessment and a detailed exploration of pathways is necessary is because there's an urgency for good interventions to be developed. And so far, siloed research has not led to those types of interventions. So we think that by looking at the totality of the environment, the likelihood that we'll find better targets for more effective interventions will come about. So that was sort of the motivation for us to do this. Now, the reality is that there were several frameworks already out there, and we did not want to reinvent the wheel. There's many of them, we mentioned them in the paper, but there were two that were very, very close, and we debated about this. Do we really need another one beyond Rachel's, Morello-Frage, and Nicole's tools frameworks that I'm going to sort of just bring to your attention right now? So there was these two that already talk about social and environmental factors in very cool ways. So this one is Rachel's framework, and it has these awesome strengths. I mean, it covers almost everything we thought it should cover. It has these multi-level interactions, community, individual. It considers stressors as well as buffers, meaning these things that have protective capacity, which we thought was very important. And something that we really admire from Rachel's framework is that is designed in a way that it allows for pathway research. Like this happens first, and then that happens, and then that happens, and so on and so forth. And we think that pathway research is very, it's necessary, especially for the development of intervention, because we want to understand the steps in the sequence between exposure and outcome so that we can figure out where in that pathway the best target for intervention exists. So this framework allows that thinking to think in this sort of process type of way. However, again, this was defined for maternal and child, and a lot of things were lumped together that we thought it would be important to separate conceptually, meaning within the social environment, you have things that you could consider as stressors or more structural sort of concepts versus things that are more fluid, like support from family members or access to certain things that might serve as buffers or amplifiers of an effect rather than the actual exposure. And we wanted to create a framework that allowed for that fluidity of how somebody could conceptualize a social factor or an environmental factor, either as a driving exposure or as a mediating factor. So we thought there was an opportunity there, but we honestly thought Rachel was close, and for the most part, this covers most of the needs. Nicole's framework did not have the pathway sort of design, but she has also these super cool things in her framework. She goes all the way to policy. She pretty much covers all the key factors that somebody would have to think about when they would really want to consider how the environment, both social and physical, affects health across the lifespan. Again, she designed this all the way to adolescence, but she does explain that expanding these ideas through the lifespan is just straightforward, and we agree with that. She conceptualizes chemical and non-chemical stressors, which we think is a very accurate way of thinking about stressors, especially when you're designing research. She has these built and natural and social environment concepts that we just thought it was so cool that she defines, for instance, crime in social, a desert environment in natural, and air pollution within the built environment. She includes policy. She has this multi-level perspective. So we thought, between the two of them, they have everything that a framework needs. Nicole is incredibly comprehensive, and Rachel's has this pathway perspective. So what we wanted to do was merge pretty much their two frameworks into one, so that we can get sort of the best from both worlds. And then, because both of their frameworks, as they were published, they were framed for maternal and child health, although they could have straightforwardly been applied to other populations and longer time spans, we thought we might as well go ahead and do that too here. So we expanded sort of the way they frame their frameworks, that we combined the coolest things of them. And honestly, I think we added very little after that. So that's sort of where our model came from. Now, the way that we developed this model, so I already mentioned that it came from the fellowship, so that's clear. The fellowship has environmental health scientists, social scientists, and epidemiologists. So all of us, so the discussions about how to think about our own research, and as we discuss our own research with each other, reveal all these connections. And that allowed sort of for the model to evolve from this natural, organic set of discussions between how we approach a similar problem from all of our different fields. And again, we developed this the last year of the fellowship. So we had a lot of thinking and discussion already executed by the time we started thinking about this. Again, we did want to have a focus on health disparities because that's what brings us all together in the fellowship. But obviously, the application of the model goes well beyond that. And we wanted to go beyond our group. The fellowship funded a meeting in Saratoga hosted by Allison, my co-leading author on the manuscript. And we brought experts that we knew are working in this boundary between the social and the physical environment, and including Rachel and Nicole. And we wanted to get their feedback, which we did, and then we improved the model. We sent the manuscript to Rachel and Nicole before submitting for publication, and that's how it came about. But that Saratoga meeting was, we think, crucial. We got a lot of feedback. A lot of elements were implemented into the model, like the cultural element. We had a strong discussion on conceptualizing community. And I'll explain all these details as I go, but that meeting was very important in the development of the model as well. So we also hope that increases the applicability of the model moving forward. So the model, it's called ISEM model and for logical purposes, but internally we call it the JPB model because they funded it, and it really aligns with the spirit of what they want to fund. The fellowship came about from their perspective, and I sincerely think that they are seriously committed to moving this field forward. So I like to market the model as a JPB model for those reasons, in hopes, I guess, of keeping their interest in this field as well. So the model starts by conceptualizing the individual and the community almost together. And that's because that's the way we think about research as well. I mean, a lot of us think about research at an individual level, although we sample as a group level, but the unit, it's an individual, whereas a whole bunch of others among this field as well, we are interested in effects at the community level. So I think these two, from a research development perspective, are conceptualized together. Now, at the individual level, we understand that there are differences, and we list a couple: age, sex, gender, that are obvious, that change the way social and environmental factors affect health. But there's way more that are there, but we did not conceptualize them in the paper that way, because a lot of them, as you start designing research, somehow fall into some other element of the research, or another component of the model. But again, the model starts with the individual. Here's where I think really the core of the model lies in, or where it came from, which is, again, this integration at the time of conception of the physical and the social environments, because we live in both. And health disparities, specifically here in the US, are driven by both. And there's strong evidence that factors from both interact, and that some of them might have synergistic effects on health and well-being. So we wanted, above everything else, for this framework to promote, support the conceptualization of research that address those two things. So the physical environment is what Nicole calls built and natural. So we wanted to simplify some concepts, so we just call it physical, but it includes those two aspects of the environment. So the built would be roads and everything that comes with it: noise, light, air pollution, and everything pretty much that has an anthropogenic source, something that was man-made, that results in a stressor. The natural environment, it's that exactly, meaning we live within varying conditions: weather, climate. Again, some of us live in the desert, some others live in cold, on warm tropic regions or cold regions, and that has an impact, and that modifies the way even social factors affect health. Again, if you're poor in the Northeast, your social position affects how you warm your house, and that has an impact. In the desert, your social position affects how you cool your house, and that has an effect, so on and so forth. The social environment are primarily structural aspects of society that drive or determine how resources or susceptibilities are distributed. But again, here we think mostly about structural things like socioeconomic position, meaning here's where it gets fuzzy, and that's sort of the point I was trying to make when the individual, I mean, it's race and ethnicity. Well, mostly ethnicity is a structural factor, and we had discussions for hours over this, and we couldn't come to an agreement. But again, no matter where you put it, it's clear that you're going to account for it. But again, the social environment, therefore, is this set of structural aspects of society that determine how resources and risks are distributed. Meaning, what is it about the social structures that determine that people of lower income live near or closer to a oil refinery, or closer to a mine, or closer to a highway, or farther from a farmer's market, so on and so forth. So those would be what we think are structural social environmental factors. Now, we know, and again, the couple of papers that I presented at the beginning, we know that these exposures have either behavioral or biological responses. So if you live in a low SES community in Oakland, you have less access to healthy food because of food deserts, and your behavior changes. And that behavior leads to biological responses. You gain weight, you have higher levels of chronic inflammation, so on and so forth. Now, the opposite also happens, meaning you could have air pollution exposure that leads to chronic inflammation, and chronic inflammation could lead to depression, and depression leads to unhealthy behaviors. So we know that the social environment and the physical environment have biological and behavioral responses, but what we wanted to emphasize is that those biological and behavioral responses interact with each other. And they actually have these positive and negative feedback loops throughout the entire model. We didn't draw them, we didn't put them there because we wanted a simple model, but they are inherently there. And again, the point of those 2 little arrows were to capture this complexity and to bring the researchers' attention to that complexity, because there is where we think there's need and opportunity for research to be done. Now, there's something in between the environment and those responses. There are these factors that modify them. Either they amplify them or they diminish them. And we call those factors resources and susceptibilities. And again, this is not clear exactly what is a resource or what it's an exposure, for instance. And I hope I'll make this point, I'll clear up this point throughout the presentation, but social support, for instance. Social support could buffer the effect of stress on inflammation. So if you conceptualize, let's say, your research that way, social support as a modifier then would be a resource. Again, you could conceptualize social support as part of the social environment. If you live in a community where most of your fellows are minority and you are a minority, and that's what you're studying. So again, it's complicated to prescribe as we detail the model where things should fall, but more importantly, where things will fall will depend on what question you're asking. But the point was for us, could we develop the model so that all the boxes exist so that researchers could put all these things in one of them? So again, we could debate for any given example where things go, but we can all agree that all those things that we might identify should be in the concept, and the model allows for that. I hope that was clear. But again, and then we also think that these resources and susceptibilities are both extrinsic and intrinsic. So an intrinsic susceptibility would be a genetic susceptibility. So it's intrinsic to the individual. They were born with this specific gene that codes for the likelihood of disease. Personality, it's something intrinsic that modifies the effect of social factors on health or behavior. Extrinsic ones could be, again, I already mentioned social support, but it could also be green space, access to parks, and access to healthcare, so on and so forth. So that would be an built environmental factor. So again, there's those sort of 2 levels. And they are affected by the environment, and they are affected in a feedback loop by behavior mostly. And in the applied example, I'll go into that as well. And then the last thing we wanted to do in terms of the core of the model was to make sure that we allowed for protective and pathways that lead to health and well-being. Sometimes, as the research of resiliency shows very clearly, even adverse exposures sometimes have positive outcomes. And that research is urgent and necessary. And we wanted to make sure that the model allowed for that. Everything else is sort of straightforward at this end. The last sort of big component of the model is that, as Nicole sort of described in her model as well, the effect or the pathways between exposure and outcome sometimes can be short, meaning within years you might connect an exposure to a health outcome, but sometimes these connections are far apart in time. And sometimes they might transcend generations. Epigenetic changes, for instance, have the possibility to connect an exposure of a parent or a grandparent with an outcome of a child or a grandchild. So we wanted to make sure that the pathways that could be targeted with the model could transcend across the lifespan and even into transgenerational perspectives as well. So this is the model altogether. Again, we wanted to simplify, we wanted to combine Rachel and Nicole's, but I do think, and this is the reason that I was the most excited to talk to you today about, because as parsimonious as the model is, it does require a lot of explanation. We think is very useful, but its applicability, it's tricky. So what I'm going to do now is discuss with you an applied example, which I hope will really highlight the utility of the ISEM model. So recently, we also published another framework, more specific, talking about a specific social factor, specific environmental factor, and in terms of health disparities specifically. So we published this early this year, almost within a month from the ISEM model. This is in Neuroscience and Biobehavior Reviews. And again, this paper proposes how these things might interact with each other, founded on the ISEM model perspective. So, for instance, we propose in that framework that early life stress programs through epigenetic changes a pro-inflammatory phenotype that sensitizes individuals to air pollution. Specifically, individuals with this phenotype have an increased inflammatory response to air pollution exposure. Therefore, these individuals over time are more likely to develop chronic inflammation and to develop it at an earlier stage. That, of course, would lead to inflammation-related disease, more likely, and also sooner. And if you see, I color-coded all of those concepts with the ISEM model. So early life stress would be a social structure, an epigenetic change would be a biological response, the pro-inflammatory phenotype, that becomes an intrinsic susceptibility program backwards by a biological response. That now makes you susceptible to new or ongoing exposures to the physical environment, in this case, air pollution. And then it leads to an adverse effect, which is chronic inflammation, which has the ultimate endpoint of disease. And inflammatory related disease, as I'm sure all of you know, include 8 out of the top 10 causes of mortality in the US. Cancers, dementia, depression, cardiovascular disease, metabolic syndrome are all inflammation related diseases. So that's how this new model connects. Now, this is what it implies in terms of health disparities. So on the y-axis, we have this risk of inflammation-related diseases. So let's call them chronic illnesses, most of them. So any given individual over time, just because of the process of aging and exposure to social and environmental factors, the risk of developing chronic illnesses, it just increases over time. So that's that. However, if an individual is exposed to childhood adversity, and that childhood adversity is severe enough as to program a pro-inflammatory phenotype, then the likelihood of increased risk of chronic illness increases. So that would be the result. So given the same exposures over time, a person with a pro-inflammatory phenotype caused by childhood adversity now suddenly has a higher risk of chronic illness, which increases over time. So childhood adversity by itself already becomes a driver of health disparities between those that were exposed to the childhood adversity and those that were not over time. Now, if we conceptualize now two groups, one, a person from a social advantageous group and one from a social disadvantageous group. Now, a susceptibility, it's immediately recognized from conception. Individuals born in socially disadvantaged group from conception because of genetic and epigenetic mechanisms, they're already born with a higher risk of developing a chronic illness over time. So that's the first thing. Given everything else the same exposure, same context, everything. Now, the other thing that happens is that that difference from conception just caused by socioeconomic position or social disadvantaged position leads to this disparity now beyond the one from childhood adversity. This is the one caused by social disadvantage. So that's the difference between the solid red line and the solid blue line. Now, there's another thing that it's also driven by social disadvantage. Individuals in most socially disadvantaged groups like poverty, low SES, minority, even gender-based and sexual-based groups have a higher likelihood of experiencing severe stress during childhood. So that likelihood of a childhood adversity event is higher among people from socially disadvantaged backgrounds. So therefore, the likelihood of a PIP is higher in the red group. Now, because the red group also, because of social disadvantage, in reality, are also exposed across their lifetime to worse environmental conditions, both socially and physically. More crime, more polluted areas. When you combine those two, now you really exemplify this double jeopardy. The reality is that the health disparity caused by social disadvantage, when you account both for exposures across the lifespan and you consider both physical and social exposures, it's way bigger than the one we thought caused by any of these factors individually. So again, in this process, I exemplify what the cause of childhood adversity would be. That's the difference between the solid blue line and the dashed blue line. What the difference would be based on social disadvantaged positions, and that would be the difference between the solid line and the solid red line. But when you account for exposures across the lifespan from every source, then the reality is that the difference is between the solid blue line and the dashed red line. And this is the effect, and we don't know what those sizes are, but this is what we're missing by conducting research independently of each other in this context. We're not assessing the entire effect of all of these things considered together. So that was one of our primary drivers as we developed this. So this is exactly what I just said. When you combine everything together, the effect is way bigger than it could be. We don't know. It could be way bigger. And in some cases, we do believe, and there's some evidence that supports the possibility of synergistic effects between these exposures. And childhood adversity and air pollution is one of them. So in summary, we hope that the ISEM model contributes a useful framework to support interdisciplinary research, to really look at how the totality of the environment affects health and well-being, both from a positive and an adverse perspective, both within short and long time frames. We think that this approach, it's necessary because we might be, one, underestimating the effects of the totality in the environment, particularly among socially disadvantaged groups, which is where the misclassification or the underestimation would have its biggest impact. And also because by studying these complex pathways, we might find better modifiable targets for intervention. So we're doing some work and some work needs to be done. But if you're looking for research ideas, so we need to understand how the environment gets under the skin. So epigenetic work, microbiome work, very important. We give those two examples in the paper. Because this, when a lot of people think about health disparities, they think in terms of behavior, meaning people of social disadvantaged groups end up with poor health outcomes because they don't eat well, because they don't exercise. But as we start understanding that biology and behavior interact at a very close level, we understand that the problem is not that simple, and stigmatizing groups is far more complicated once you understand that behavior is not completely a function of will, but that environmental factors and biological pathways have a strong influence on behavior. So we think that's very important. So that brings to that second point for the need of biobehavioral pathways. Again, one example that I just gave you was exposure, inflammation, behavior, which leads to more inflammation, which then increases the likelihood of a negative health point. Identifying protective social environmental factors. This is where, again, the opportunity for intervention. Sometimes prescribing somebody to move away from traffic, to avoid noise, it's sometimes, or avoid crime prone neighborhoods, is not feasible for a lot of individuals. But if we identify, for instance, that social support, that access to green spaces, that attachments with peers and friends are protective at a cellular level, then we provide useful, feasible, pragmatic opportunities for intervention. I know that ideally we all hope that we would just prescribe somebody not to be poor anymore, but in reality and in the short term, that's not going to happen. So figuring ways to buffer effectively and meaningfully socially disadvantaged individuals from the harm of adverse environmental conditions is important, and these social environmental interactions allow us to look into that. And of course, longitudinal and mediation analysis are necessary. Cross-sectional work is awesome, and in this case it's also necessary. We need to start proving, and actually that's what we're working on right now, creating data to support hypotheses, but primarily with the aim of generating longitudinal work that really starts to support the pathways. So that's a lot of opportunities there for any of you that might be interested in or are already working in this field. One of the things we're doing here, so we're tackling that air pollution, that the environment and social, and we launched 4 years ago a nursing student study here at UTEP. We have been recruiting every incoming nursing student with a 85-90% success rate in terms of recruitment. Our cohort right now, it's a little bit above 500 students, and we hope to study them as they transition from nursing school to the nursing working environment. The reason that we think nursing students are an ideal group is twofold. One, stress in nursing, especially the first couple of years, as all of you know, is very high. It impacts the bottom line at hospitals. It impacts the bottom line in terms of patient health, in terms of public health, turnover and attrition. So understanding stress is very important, but this group and this high stress exposure also offers another interesting research possibility. So we can research for those purposes, but at the same time, research how these other environmental factors modify what we already know is going to happen to a lot of them, which is this high stress exposure and the adverse health outcomes and engagement outcomes that comes with them. So we developed this study, and we're studying specifically metabolic and mental health on our students. We're looking at metabolic syndrome, atherosclerosis, among other things. We're looking at subclinical inflammation. We're looking at this pro-inflammatory phenotype. We're assessing their early life stress. Actually, we're assessing their entire life stress to see what types of stressors and when does these stressors might program the inflammatory phenotype. We're collecting RNA for epigenetic analysis. We're looking at engagement and performance so that the nursing field it's informed, so that schools of nursing are informed on how to better prepare the students. But we're also asking the questions that are relevant to the framework. We're looking at how, for instance, air pollution, traffic noise, light, greenness, access to greenness modifies the effect of stress on performance and health. And we're looking also at those intrinsic factors like personality, emotional intelligence, stress coping, and IQ. So it's a very comprehensive study. We just submitted our second manuscript, the one that describes the manuscript to nursing research. We're crossing our fingers, and I'll share that information with you guys if when it gets published, I hope. And but so keep an eye on the study. We have a lot of data, so if anybody is interested on questions about the data I just mentioned, feel free to send me an email. We're open to collaborations. We're already working with a lot of people. And again, all of this work is done here at the School of Nursing. We have a really cool biobehavioral research lab, and if there's anything we can collaborate with any of you, feel free to send me an email, shoot me a call. We have some good both biomedical and psychometric capacity, and we'll gladly share our capacity and experience with any of you if you need it. So I'll stop there. I don't know how we're doing in time.
So, hey, Hector, can you hear me?
Yes.
Yes. Okay. Great. So sorry, I can't see the screen, and I think that others cannot speak. I apologize for that. It seems like I have said it in the wrong way, the webinar. But anyway, I thank you so much for a great presentation. I had your slides, and I just listened through the phone. But would you please go ahead to the messages and see if there is any question? There might be some questions submitted by the audience. If you would, please, Hector.
Yes. Yeah, no, I don't think we have questions. But again, if anybody does, they can forward them to me via email.
Yeah, wonderful. So, yeah, you will probably get from us some emails and some questions. And again, thank you so much for a great presentation. And we may invite you again because, this one, I think that we couldn't even record it. And so that would be something that people are really willing to listen. When your next paper comes out, please inform us, and then we will get back to you and invite you again for your presentation. And we enjoyed it, actually. Thank you so much.
Yeah, thank you.
I appreciate it. So bye-bye for now.
Yes, thank you. Bye-bye.